Okay, by my clock, it's 3 past. So let's get started. Welcome, I'm Eric Relnick. I'm an emergency medicine physician in Boston and one of the co-leads of our Global Mass Vaccination Collaborative. We're really excited today to hear about some work on the front lines by Dr. Hilarious Abiwu, who's leading efforts in Ghana on a multi-pronged strategy. Next slide. Here's some guidance and instructions for us today. Please mute yourself during the meeting today. You can be on or off screen, whatever you're comfortable with. Use the reactions buttons that are at the bottom of the screen and raise your hand during the session if you'd like to speak. You can engage in dialogue with anyone that's on here, and the idea really is for us to have real conversations with each other. Our format is essentially to do a quick run through of our organizations, the Global Mass Vax Collaborative, hear from Dr. Abiwu, and then open it up for questions. And we have a fair amount of time for questions today. We should have about 30 minutes to really engage in conversation. I'm sorry, Arabi, do you have a question? Okay, Arabi, it looks like your hand's up, so I was just calling you out. Thank you. Next slide. So what is a Global Mass Vaccination Site Collaborative? It's a group that we started in the United States in 2021 at the beginning of the year, understanding the challenges of logistics, rollout, deployment, and implementation of vaccines. When we were scaling to multiple mass vaccination sites, we then scaled to other sites across the globe, including India, Brazil, Haiti. And then in the sort of some time, we're connected with Boost, who has led globally for many years on vaccination efforts. And we're going to hear more about that from Jenna. And under the Gates Foundation, who are now supporting our work, we set up this Global Mass Vaccination Collaborative, which is really focused on an online learning community with the aim of having these webinars or live discussions and exchange of information. 2, consultation with subject matter experts as needed. 3 is an open access website, which has a variety of different resources. And I think someone will put that in the chat in a moment, which includes documents, checklists, articles that can help support mass vaccination sites. And the term mass vaccination sites, I think we're all trying to figure out what that means, but really the idea is that could be a vaccinodrome, that could be smaller sites, larger sites. The intent here is really to share different methods of helping affect logistics and implementation to optimize needles and arms to help our colleagues. Next slide. Jenna is going to speak about Boost. Jenna.
Thank you, Eric, and hi, everyone. Welcome to today's session. I'm Jenna Groman. I'm the Director of Global Communities of Practice at the Sabin Vaccine Institute. And Boost, as Eric mentioned, is partnered with Ariadne Labs to drive forward this Global Mass Vaccination Site Collaborative. Boost is a global community of more than 2,000 immunization professionals from 135 countries. And our goal is really to enable you and all of the immunization professionals to connect with peers and experts, learn skills to build capacity and advance careers, and lead immunization programs in challenging contexts. So this is an open community. We welcome you all to join us for both not only these conversations, but join us to continue our ongoing conversations about all immunization programming. Back over to you, Eric.
Thanks, Jenna. Yeah, Boost is really amazing. The website is awesome. The communities are awesome. So go for it. It's a free open access community that everyone should take advantage of. Thanks, Jenna. Next slide. Ariadne Labs is a joint program between the Harvard School of Public Health and the Brigham and Women's Hospital, which is an affiliate of Harvard Medical School. Our focus is implementation, taking ideas, piloting them and scaling them globally. We've worked on various projects across the globe with more than 165 countries. Right now, we're talking about vaccine delivery, but we have different programs and efforts in a variety of different domains. And we're really excited and privileged to listen to you today and understand your needs and march forward with ways that we can help deploy vaccines across the globe. Next slide. So today we're really honored and privileged to hear from Dr. Hilarious Abiwu. Dr. Abiwu will discuss the case study of organizing COVID-19 mass vaccination efforts in the northern region of Ghana from his perspective as Deputy Director of Public Health, Northern Regional Health Directorate. His presentation will include campaign objectives, strategies, sites, preliminary results of their work. He'll also share insights on successes and challenges of their mass vaccination efforts, as well as photographs of past sites. So without further ado, I'll turn over to Dr. Abiwu. Thank you, sir.
Right, thank you so much for that introduction. Like you rightly said, I'll be sharing some experiences as far as the rollout of COVID-19 vaccination is concerned in the northern region of Ghana. Next slide, please. Next slide. So essentially, the discussion will be centered around providing some background, key strategic objectives as far as the COVID-19 response is concerned, and how the COVID-19 vaccination efforts were grounded in these objectives. We'll also look at a summary of the COVID-19 situation in the region. Then now we move to the COVID-19 vaccination itself, focusing largely on the mass vaccination drives. Share some preliminary results, some of the things that I think gave us some successes, some of the challenges we are confronted with, and the way forward. Next slide, please. Right, so essentially the map on the left of the screen is a map of Ghana, and northern region is highlighted in blue. The northern region is one out of 16 administrative regions in the country. Coincidentally, the map on the right, which is the map of the northern region, also has 16 administrative districts. Right, next slide. Right, so the northern region recorded its first confirmed case of COVID-19 25th of March 2020, and that had to do with some imported cases. Then 2 weeks after the country recorded its first case, and that was in the national capital, Accra. But subsequently, on the 16th of April, the northern region recorded its own first case. So immediately after that, the region initiated a coordinated response to the outbreak. Now, the response was centered around a number of themes. First of all, leadership and coordination, surveillance and contact tracing, testing and laboratory services, management of cases, and also risk communication. Next slide, please. Now, so at the very beginning of the response to the outbreak, the northern region came up with 4 strategic objectives to guide the approach to responding to the COVID-19 outbreak in the northern region. Well, the first one is to contain the infection, limit its spread, and also ensure that our health facilities in the region are not overwhelmed. And the COVID vaccination efforts are rooted in these very first objectives. But besides that, we also aim to mitigate the impact of the outbreak response on the provision of routine services. The outbreaks like this also present opportunities to strengthen our healthcare system. And so we're conscious about it to try and see how we could use the resources that will come as part of the response to strengthen the health system in the northern region. Then we are also conscious of the fact that the national response also has its own strategic objectives. And so we're conscious to try and align some of the activities we engage in with the national strategic goals. Next slide. Next slide, please. Right, so this slide essentially gives us an idea the number of COVID-19 vaccines that we have received in the region as at the 10th of February 2022. After that, we are currently receiving additional consignments of vaccines into the region. But as of the 10th of February this year, these were the vaccines that were received. In all, we had received up to about 1 million, a little over 1 million doses of COVID vaccines. Majority of these were AstraZeneca vaccines, and then we have some Johnson & Johnson and Pfizer, and then Moderna in the as one of the minority. So as of the middle of February, we had deployed close to 740,000 doses to our 16 districts for use. Next slide. Right, so now the previous slide, please. Right, so in delivering the vaccines, we were guided by our own contextual issues. The first one is that generally in the northern region, significant proportion of the population believe that COVID-19 doesn't exist. For those who believe that COVID-19 exists, also thought that it wasn't a major health issue for them. And that's partly also because some of the initial people who got COVID-19 that we did contact tracing on, at the time of getting to them, some of them were actually working in the farms. So it gave an initial impression that, okay, either this thing doesn't exist, or even if it does exist, I mean, it's not a serious issue to contend with. Now, so as we kept on engaging the population, some of the feedback we got from the population was that, look, we don't think this is a problem for us, but at least we trust the healthcare workers that they want to safeguard our lives. So if you really want us to take these vaccines, then we're not going to come chasing you for the vaccines. You can bring them to us. If you bring them to us, we'll take them. But don't expect that we're going to leave our busy schedules to come chasing you for the vaccines. But then we also have some group of the population that needed these vaccines for other reasons, like if they had to travel, they needed the vaccination certificate and all that. And then, of course, the few people who understood the issue and the seriousness of the COVID-19 disease and were eager.
Oui, c'est elle qui parle.
Je mets les écouteurs, you don't want to understand.
Je pas les écouteurs. Je vais.
Right. So based on these understanding, in deploying our vaccines, we use two approaches. First of all, we identified our healthcare facilities as points of vaccination. So we communicate to the population that anybody who wanted any vaccination or COVID vaccination could walk into any of our healthcare facilities and would be attended to. And in addition to that, we have some strategic points within communities where we set up vaccination spots. And so people within the communities, apart from going to the healthcare facilities, could also visit these centers to get vaccinated. But because we knew that the population, the majority of them were asking that if you need us to take these vaccines, then you need to bring the vaccine over to us. We had also implemented mobile teams, and these use about 3 approaches. First of all, we had teams that were moving from house to house. literally engaging people in their house, and those who willing to take the vaccines are vaccinated in their house, and then they move to the next house and continue with the vaccination. Then we also identified places where people congregate in large numbers. For instance, we had our sports stadiums where football matches were ongoing. There were, large crowds gathered there. We had markets where usually we have a lot of people, those selling, and then those who are coming to the markets to patronize those places. We had bar stations, and usually these are very, very busy enclaves where there are a lot of people coming in and people going out, and then you have all these transport unions there. Then we have organized groups, and sometimes these are like professional groups. So we have persons with disability who may ask that we want to organize our group so that you come and deliver the vaccines to us. Or you have a church, and then the leadership says that, look, we have our church service here. Could you come and vaccinate our teams for us? And so on and so on. So these were the key strategies that we employed in delivering the vaccines to the community. So I'll move on to explain a bit further on how we approach the mass vaccination campaigns. Next slide, please. Right, so like I indicated previously, in the northern region, particularly at the capital, we have one of the sporting clubs, which is part of the Premier League. So occasionally we get matches played at the Tamale Sports Stadium. Coincidentally, a number of the Football Association members are also staff of the Ghana Health Service. So working with the FA, we first of all were responsible for vaccinating the team officials as well as the players. Then engaging with them, we get to deploy our vaccination teams to the stadiums on the days that football matches were to be played. And whilst that is ongoing, we work with our health promotion teams and the National Commission on Civic Education to continuously educate and mobilize the people who are gathered in and around the stadium and within the stadiums, telling them about the presence of the vaccination teams in the stadium so that they could come out and get vaccinated. Now, the country also celebrated its Independence Day on the 6th of March. And so mass gatherings, parades were organized in all the regional capitals and district capitals. And so working with the local government at the regional and also at the district level, we also deployed vaccination teams to these places, to get people vaccinated. Now, on Fridays, in the northern region, the predominant religion is Islam. So Fridays are when people have congregational prayers. So quite a large number of worshippers usually will go to the mosque on Fridays and have, their vaccination done, their prayers carried out. So before these Fridays, we usually would engage the imams, who are the religious leaders in these mosques, and then also go around and make announcements in the communities in and around the mosques that we are targeting for the Friday, informing them that we're going to deploy vaccination teams to these mosques. And so they could come early with their identities, to be registered and vaccinated. And then also during the worship sessions, the imams and leaders also announce and encourage their congregations, to visit the vaccination points that were set up around the mosque to get vaccinated. In one of these instances, for instance, we had churches who had retreats, what they usually will call retreats. And then we engage the organizers and they allow us to set up vaccination camps within the retreat grounds. In one of those retreats, particularly in Tamale, we had a church that had an assembly of close to 3,000, between 3,000 and 4,000 that had gathered for some convention. And along the line, the head pastor had some symptoms and so was tested during the convention and tested positive. So it became an opportunity to engage him, because originally they were a bit hesitant to getting vaccination teams deployed to the area. But then we indicated that one way, to ensure that the exercise, the convention continued, was to protect the congregation, by vaccinating them. And that was quite acceptable to the church. And then they quickly invited us to set up vaccination teams within the retreat grounds. And then we had quite the majority of the congregants who were not vaccinated, during the sessions. We have had engagements with the Ghana Education Service, both at the national level, regional level, and district level. So we work with the teachers in these schools, and then they organize the students who are eligible to be vaccinated from 15 years and above. And then we deploy our vaccination teams into those schools until everybody who was eligible gets vaccinated. Now, marketplaces were also another place that we had to use. And in deploying to the markets, the first thing we usually would do would be to engage the leaders of these markets that they call the market queens. So we have meetings with the market queens, explain to them the need to get their traders to be vaccinated, and then also allow us, to set up vaccination teams at various points of entry and exit in the market. So on specific market days where we have large numbers of traders as well as buyers coming around, we set up these vaccination teams. Again, we work with the National Commission on Civic Education that will deploy vans, making continuous announcements in and around the marketplaces and surrounding areas in order to mobilize people to come to the points of vaccination to be vaccinated. And then a few bus stations were also used in these exercises. Next slide. So this picture essentially is to show some of the vaccination that were carried out in senior high schools. So essentially they give us a specific date, and then the teachers organize the students, and then they line up, get vaccinated, and get back to their classrooms to be observed before they finally file out. So these were a number of schools that were visited within the region. Next slide. So here it's a marketplace, where some of our vaccination teams were deployed. So normally we don't have camp out logistics to probably say set up a tent, movable tables and things like that to get the teams properly set up in some of these markets. So usually once we engage the market queens, any table or space that is immediately available, our teams simply set up there, and then they continue the announcements and vaccinate the people. And this is one of those sessions that were held in some of our districts. Next slide. So like I indicated on our Independence Day, we had our teams deployed to some of these parade grounds, also working with our telecom companies, because currently there's mass re-registration of SIM cards by our telcos. And so they usually will set up camps, and we have, large crowds and queues, waiting to have their SIMs registered. So we set up with them and get some of the people who are coming to register their SIMs vaccinated, and also the people who came for the parade. Next slide. So again, this was one of those setups at the parade ground in Tamale. And the yellow tent there was for the telecommunication company. They had a tent, to set up, but our teams didn't have that, for their setup. Next slide. Okay, so these vaccinations were going on routinely. So, from 2021, almost every month, based on the availability of vaccines, we deploy these vaccines. But in February, the expanded program on immunization at the national level had discussions and indicated that we needed to do mass vaccination campaign week. So we had, apart from what we were doing routinely, we had to mobilize additional human resource and teams, volunteers, in order to move into communities that have not been reached as yet. Next slide. So based on the various strategies that I've discussed, which were used in this campaign exercise, each region was given some targets to be able to reach, and then the vaccines were deployed to the regions. This slide is not very clear, but as of the 11th of February, when these national COVID-19 vaccination days were being rolled out, the northern region had utilized close to about 95.9% of the vaccines that had been deployed for use within the campaign period. And that's the first bar, followed by the other regions. Next slide, please. Okay, so this slide also tries to show the general picture as far as the vaccination efforts are concerned in the region. Now, on the left side of the screen is a graph showing the percentage of the target population that has had a single dose of the vaccine. Now, currently, as we speak, it's only one district, which is in deep green, which means that more than 60% of the population in that district have had at least one dose of COVID-19 vaccine. The target for the country was based on the declaration of the president, who says that we needed to vaccinate at least 70% of the eligible population. And so that is the minimum target that we are all working towards at this moment. And it is only one district, two districts currently that are doing less than 30% of the target population receiving just one dose. On the right side of the screen shows the map of districts in terms of how many of this target population have received 2 doses. And as you could see, we have just about 6 districts that have between 16 and 30% of the target population getting 2 doses of the vaccine. The majority of the districts, you know, are still having less than 15% of the population getting 2 doses. So we have quite a long way to go in terms of getting our target as was communicated by the president. And a number of these have been contributed in the beginning by the non-availability of vaccines for the population. Next slide, please. So this is just again a summary of the general situation by district in the northern region. So overall, the northern region is doing about 39.1% of the target population receiving at least 1 dose, and just about 16% of the target population receiving 2 doses. Based on the target and the population of the northern region, which is about 2 million people, we are hoping to vaccinate about 1.2, a little over 1.2 million people in the region. But as we speak, we have just been able to dose about 493,000 people. So we have quite a bit of time, a bit of population to cover in the coming days. And we are hopeful that we can achieve this target by the middle of this year, June. Next slide. Right, so for some of the successes that we have achieved over the period, we think that the engagement of various stakeholders, the Ghana Education Service, market queens, transport unions, chiefs and opinion leaders, football associations, religious leaders, have largely contributed to some of the successes we have achieved, bearing in mind that at the very beginning of these COVID-19 vaccine rollout, there were very high levels of vaccinacy within the population and also within healthcare workers who were supposed to deploy these vaccines. But anytime we engage trusted individuals within various targeted population to engage their followers, we seem to get quite a lot of improvement in terms of the uptake of the vaccines. It's also important to indicate that the country, Ghana itself, has had quite a strong expanded program on immunization program. And that formed the bedrock based on some of the experiences that we have had in terms of rolling out various vaccination campaigns, including yellow fever, polio, and all of that. So that's also helped significantly in driving the rollout of the COVID-19 vaccination in the northern region. Next slide. So what are some of the challenges? Again, we have vaccines. This is one of the longest vaccination exercises or campaigns we have had to hold. So for almost a year now, every month, we have to be rolling out vaccines. And we have to move out to reach the communities and the individuals in their various homes. This means that you need to provide funding for healthcare workers to fuel their movement and also for other incidental costs as they move out to roll out these vaccines. And the funding has not been adequate. So anytime we have funding to go, we seem to get quite a lot of high uptake. And anytime funds dwindle, the momentum in terms of vaccine rollout also reduces. Then also generally for COVID-19 vaccines, the shelf life is quite short. And because we do not produce the vaccines in country, by the time vaccines get to us, we have maybe a month or two in order to get these vaccines used. So constantly we are on the neck of our staff, to get the vaccines out so that they do not expire. And that seems to give a lot of fatigue among our staff and also threatens, disruption of our routine vaccination campaigns. Now, if you look at some of the pictures I shared in terms of vaccinating in these mass gatherings and things like that, the logistical support and camp out items like chairs, tents, tables, and things like that to make life a bit comfortable for our vaccination teams is lacking. And that becomes a bit of a challenge for our teams, even though they keep on pushing on. We have also issues with data management, because if you have to do these kinds of mass vaccination and do a second dose and even booster doses, it meant that we needed to deploy some form of an electronic immunization registry, which the national team has rolled out. But because we don't have network connectivity across the country uniformly, we have some challenges with capturing data in the vaccine rollout. And this is being worked on quite strongly. Again, one of the other things we have had to do to try and offset some of these challenges has been to mobilize additional staff who typically were not involved in vaccination or who were not actively involved in vaccinating. In part of the region, we have had to fall on health workers who were trained but have not yet been employed into the service in order to boost our vaccination teams so that we don't end up deploying all our staff on COVID-19 vaccination to the detriment of routine vaccination. Next slide. So the way forward has been to seek support to procure items to set up some of these mass vaccination sites, because our markets are constantly busy, our bar stations are constantly busy, and if we have to get our teams there more comfortably over a long and more sustained period, we need to get some of these camp items to make life a little comfortable for them. And this, we are engaging some of our partners. Currently, as we speak, we have global communities that is being supported by USAID to help us, improve on some of these logistical challenges. we're integrating COVID-19 vaccination with other routine vaccines. And then also—
This meeting is being recorded.
In terms of the issues with the app, we are relying more on the offline version of the vaccine app, and then also providing more mobile phones and tablets for our vaccination teams to capture these data offline, and then they move into areas of good network and then upload or synchronize their data. Next slide, please. So generally, we've had quite a strong support from the regional management team, our district health management team and staff, Ghana Health Service at the national level, international stakeholders like Gavi, WHO, CDC, UNICEF, GES, and quite a large number of in-country NGOs or non-for-profits that have been very supportive in helping us to be able to roll out these vaccination campaigns. And of course, a number of our staff have also been involved in the boost programs. And so that has also provided significant ideas for most of our team leads in terms of how to apply some of the knowledge that we have learned from across other countries within the boost community and other platforms in order to make these vaccination exercises go on quite smoothly. Thank you very much.
Awesome. Well, thanks so much, Dr. Abiwu. That was really fantastic. We want to open it now to some questions. I already saw there was one question in the chat from Sofo, and they asked, how are you managing vaccine hesitancy in the region?
Right. So, like I indicated in the beginning, there's a general perception within the region that COVID-19 doesn't exist. There are those also who feel that, well, even if it does, I mean, it's not a serious issue that should engage their attention as such. So one of the things we have had to do is to collaborate with the national team, the Health Promotion Division. They've carried out a number of surveys within healthcare workers and also within the communities to try and identify some of the reasons for vaccine hesitancy. And these reports have been shared with us. So on the basis of some of the reasons why people will not want to take the vaccines, we've mounted up some social mobilization and risk communication activities. We've been on radios, we've been on television, we've had community engagements with some other support from other organizations like the PIGO and some other USAID funded organization and many others. So we try to engage community by community depending on the reasons that are coming out from the communities as reasons why they do not want to take the vaccines. We've had instances where a whole community, the vaccination teams are barred from entering those communities. And usually the chiefs in those communities are against the vaccination exercise. And usually we try to understand what the reasons are. And sometimes when we get into, you find that it's just a matter of trust. So in one of those instances, we've had to fall back on staff who are members of that community, but are not working there, but who hold the trust of the communities to engage with the chiefs and people. And after a number of engagements, the chiefs themselves get vaccinated and also encourage their communities to get vaccinated. And we've been able to get into those communities to get them vaccinated. So the reasons for the hesitancy are many and varied, and also vary from community to community. So depending on which community we are dealing with, we try to tailor the response to that community to try and overcome the hesitancy. We still have some level of hesitancy, but increasingly we are making headway with it. Over.
Great, thank you. Does anyone else have any comments on hesitancy? Anything you've done locally that you want to share with others? If you do, could you raise your hand? Okay, we'll keep moving. Lots of great questions in the chat. If you do have questions or observations, raise your hand, put them in the chat. Next one is from Eva. They said, could you speak more about efforts to integrate COVID-19 vaccine with other vaccines or any other intervention or commodity?
Right. So one of the key strategic objectives we set out at the beginning of the COVID-19 outbreak response was to mitigate the impact of the response actions on routine services. So again, at the very early in the outbreak, we've had some support from the national level, providing some guidelines and training in terms of how we could continue to provide routine services as we mount the response to COVID-19 outbreak. Now, when we got the COVID vaccines into the region, we didn't have a lot of vaccines in the beginning. So in the initial stages, it wasn't a problem. So we only set out periods for the vaccination, roll out those vaccines and wait, go back to our routine activities and wait for the next batch of vaccines until towards the last quarter of last year that we had an influx of consignments of COVID vaccine into the region. So for instance, what we have had to do is to train a lot more staff to be involved in the COVID-19 vaccination. So in a district, if you train, say, about 60 people, you're going to divide them into groups of 3. So at any one point in time, you have about 20 people who are constantly involved in COVID vaccination, whilst the other 40 are involved in providing other routine services and immunization services. Now, and then in the next month, the next batch could also get to do the COVID vaccination, and then the others go back to routine immunization. Now, at the facility level, in terms of the fixed vaccination exercises, so at the health facility level where we have vaccination teams there, usually these are the same people that provide routine immunization. So as people walk in to get vaccinated for their COVID vaccines, they also provide their routine immunization services. The team that we have not been too successful with is the teams that move out into the communities to get people vaccinated, maybe at the stadiums and then the market. And the difficulty with it is that majority of our vaccination efforts in the expanded program on immunization is on children. And we don't have an electronic immunization registry for these children. So if you need to vaccinate them, they will need to come with their maternal and child health record books. And so that becomes a bit difficult if they are not targeted or you don't meet them with these cards. So that has been the difficult part. But otherwise, generally, we just try to get a team that is, focused on the COVID vaccination, and at the static points where we usually carry out routine vaccinations, we just carry COVID-19 vaccines along to have our other people vaccinated. So far, that's how we've managed the situation.
Great.
Over.
Great. Another question from Izahaku. They asked, does the COVID-19 mass vaccination affect routine services in the health facilities, since the same staff engaged in the exercise are the same rendering routine services?
Right. So at the moment, from the data we have in terms of our immunization coverages, I would say that the COVID vaccination exercise has not significantly affected our routine vaccination efforts. And that's largely because under the leadership of the regional director, who is a very experienced public health practitioner and then a consultant for WHO on a number of these outbreaks, there's been constant communication in terms of how to strategize in such a way that the inadvertent effects of responding to the COVID-19 outbreak does not become worse than what the outbreak itself will bring onto the population if we hadn't even responded. So at every opportunity, there's engagement with the leadership at the various levels, district levels, to try and make sure that there's a clear plan to
The recording has stopped.
continue routine vaccination exercises, whilst
This meeting is being recorded.
Carrying out the COVID-19 vaccination. So far, we haven't had any significant impact on routine services. And like I indicated, generally, there are a number of our staff, some of the staff who, before COVID-19, were providing some supportive roles in our health care centers, in our district health directorate. Usually, they sit in the office, providing advice and guidance to community health nurses who are on the front line. But in the COVID-19 vaccination exercise, we've had our disease control officers, field technicians, nutrition officers, all of them trained to provide vaccination exercise. And also the fact that because we provide some minimal allowances for people to take lunch when they go for these mass vaccination campaigns, we've been able to get some of our healthcare workers who are not yet employed within the Ministry of Health, to be part of the exercise. That lessened the burden on the existing staff as far as the COVID-19 vaccination is concerned.
Great. Thank you. Next question is from Jeff Red. As a country, are we going to continue the vaccination in this manner where some of the vaccines come near expiration, putting a lot of pressure on the vaccinators and district teams? What are the strategies for COVID vaccine deployment for smooth running like routine immunization going forward? Jeffred, when you ask as a country, are you asking about Ghana specifically, or where are you asking about? Maybe you can put it in the chat. Wasn't clear, but maybe you can answer, Hilarious, from your perspective as a country, from your perspective.
Right. So I think that the general thinking of the national team, as far as the COVID-19 vaccination is concerned, is to quickly reach the target of vaccinating at least 70% of the population quickly, so that the COVID vaccination becomes more like a routine part of routine services that are provided. So for instance, in February, when we had these national COVID-19 vaccination days, or a 7-day campaign, we realized the uptake was significantly higher compared with the monthly ones we're doing. So the plans are that in the month of April, for instance, there are 2 of those mass campaigns that are going to be held, each of 7 days duration each. And the thinking is that with these intensified campaigns, we'll be able to quickly reach the minimum target, and then we can revert to providing routine COVID-19 vaccination alongside other vaccinations that have been happening in the health care system. So for now, the approach is not too different, except for these frequent mass campaigns that are to be held. And the target is that between now and the end of June, we should be able to hit these 70% of the population that have been vaccinated, so that we can revert to integrating largely the vaccination along routine activities.
Great.
Over.
Perfect. So Louis Dang asked, thank you for the wonderful presentation, the efforts. What are the successes regarding strategies to overcome COVID-19 hesitancy? I think we addressed that earlier from Sofo's question. Martha asked, please, what are the strategies put in place to manage rumors? I think you touched on this a little bit, but any other strategies you have around addressing rumors? Hilarious.
Okay, so with support from US CDC, particularly in the northern region, we've been able to set up an EOC, a very modern setup with applications that monitor for rumors and discussions on radio, social media, and things like that. So periodically, we get an insight into what the discussion and engagement is like, on various media. And then we provide these information to our various districts and teams through various avenues at every opportunity that we meet. And this is supposed to help them target their social mobilization efforts and then the risk communication. Now, additionally, this month, we've had discussions with USAID again through their partners, global communities, to focus, to do a quick survey at our antenatal clinics on pregnant women, because that has been an area that we haven't gained so much success as yet. Do a survey, try to find out whether the pregnant women will be willing to take the COVID vaccines. And if they will not take it, what will be the reasons why they are not going to take these vaccines and so on. And then quickly collect the data, analyze it, and use it to target or to shape our risk communication efforts in our antenatal clinics. And we're doing this because we realize that at the introduction of vaccination, COVID-19 vaccination for pregnant women, particularly in the Volta region, they realized that attendance at antenatal clinics dropped, significantly. And this was because there was rumors about the COVID vaccine being a family planning intervention. And so they felt that because they were refusing the uptake of the vaccines, now the pregnant women who are seen to be the fertile people now were being targeted. So at some point they had to make a decision to hold on with these vaccination exercises at the antenatal clinics. So learning from that, we thought that we needed to be able to engage our pregnant women to try and get a sense of what is going on in their minds, and then we can craft appropriate strategies to target pregnant women coming to our antenatal clinics and in our communities in order to help reduce hesitancy, that may exist within that target population. So that's just the addition to provide as far as how we are dealing with vaccine hesitancy. Over.
Great. There are a couple of questions that came in from Rafa Rasonanya, Yvonne. Both of them seem to be addressed through Martha's question earlier. And I think you've really touched also on communication strategies that were used to drive vaccination demand. So I'm going to skip over those for now. Stephanie asked, what has been the COVID infection hospitalization rate in Ghana? And do you have a sense of how vaccination has affected that rate of infection?
Sorry, I missed a bit of that question.
Sure,
please.
sure. What has been the COVID-19 infection hospitalization rate in Ghana in general? And do you have a sense of how vaccinations have affected the rates of infection?
Right. So if I look at the situational report as at yesterday, for Ghana, we had about 90 active cases, and serious and critical cases is only one from the situational report as at the 24th of this month. Now, so the general situation at this moment is that the rate of hospitalization has declined quite significantly. And then also the numbers of active cases has declined. So in the northern region specifically, for instance, on record, we do not have any active cases as of today. So generally, even the engagement surrounding COVID-19 has gone down a bit. And this appears also to be affecting the vaccination drive, because at the peak of the outbreak, when we have high hospitalization, both in country and then on the global scene, there was a certain level of urgency, within the population to get vaccinated. But these days, there's very little national discourse on COVID-19 and even at the global level. So we have to actively engage the communities in order to be able to get the vaccination exercise going. Over.
Great. Let's see. I think we've got all the questions addressed in the chat. It's 8:57. Oh, I got one more that just popped in. This is from Bakur, and it says, are there plans for manufacturers to manufacture vaccines in small doses, 2 to 3 dose vials, so to reduce wastage and waiting time? Because with the 10 dose vials, vaccinators would sometimes let vaccines wait for a good number of people to gather before a vial is open. I can make a comment, but go ahead, Hilarious.
Right. So apart from knowing that Ghana is collaborating with some other African countries under the auspices of the AU, to have vaccines produced on the continent, I'm not aware that specifically there's some attempt to produce multi-dose vials, in terms of the number of doses per vial, to say 3 or 4 or 5. That information is not available to me. But then just to quickly add that the wastage rates we have observed in COVID-19 vaccination are significantly lower than what we see in routine vaccinations. And that's largely because of the approach of targeting mass groups and also doing house-to-house vaccinations and things like that. So compared with other routine vaccines, the wastage rate, except for, those vaccines that expire, the routine open dose wastages have been on the lower side comparatively. Over.
Great. Well, thanks for that. That's one thing we can bring back, MassVax team. We can bring that back, maybe the Implementer Action Network around this question and concern around vials and wastage. So we're at the end of the hour. We went through it so quick. I think we learned a lot. Hilarious. We are incredibly thankful for you, your leadership, and sharing your lessons learned and teaching us all so much. And for us as a community, for each of you, thank you for your questions. Keep them coming. Please go to our Global MassVax website, globalmassvaccination.com. Give us feedback on the resources and how we can help you. Take our survey to learn more about you and your sites, and join the Boost community at boostcommunity.org. Hope everyone has a great rest of their Friday and a great weekend. And we are out. Have a good day. Bye.